On this episode of the Ask Mike Reinold Show, we talk about how we determine loading in the rehab process, training with bare feet, and our recommendations for dry needling certification courses.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. I am up here at Champion PT and Performance up in Boston. I'm here with the crew as usual. Lenny Macrina, Director of Physical Therapy, co-owner.
Double fisting.
Double fisting. My coffee's over there. I got to get that. Lenny Macrina. Website is championptandperformance.com.
Yeah, exactly.
Dan Pope. Lenny doesn't have a website. Dan Pope from Fitness Pain Free, one of our PTs here. Dave Tilley from shiftmovementscience.com. We're here. And we got a new student to introduce to everybody today. New student, right, is Joe Coppola. Joe Coppola. I screwed it up. I knew I did it.
Joe Coppola.
Joe Coppola from Stony Brook in New York. Are you a Yankee fan, kid?
No.
He's not a Yankee fan. How about you want to do this whole episode with a Boston accent?
Lenny's got it. That's easy.
With our normal accent,
we'll do opposites.
just do the whole thing.
Make my smart stop.
You know what I forgot to tell you?
Smart stop.
We just said we got to go fast today, but you know what I forgot to tell you? I got an email. How about this one? I got an email from a listener the other day that said they were watching our podcast with closed caption on. It was muted because they're in front of their students or something. This was Timo, by the way, from Birmingham.
Right.
In front of their students, and the closed captioning was on, and the F word came up as a closed captioning, and I'm like, there's no way we don't swear on camera live. We swear after the episode. We don't swear on camera live, but I think it was like Lenny must have said like patella and
a spoon and a fork.
Yeah, it's like,
I eat with a spoon, a knife, and a fork.
That was the only thing else I could think of was that Lenny's Boston accent. But anyway, so Joe, a new student from Stony Brook. It's Joe Coppolo. Jojo Coppolo is his nickname, Jojo. So Jojo, start off. Let's hit up some questions today.
All right. Amy from NC. Hey, Champion Crew. Two-part question for you. What methods do you guys use to determine resistance/load in rehab? Example, 10 rep max. And number two is, what are your thoughts on RPEs and the determination of load?
So, all right. So question one, how do we determine loading in rehab? What do you guys think? This is something we actually talk about a lot here.
Well, I think that in the acute phases of any injury, it's very hard to because it's sub-maximal loading for the majority of what you're doing in the beginning. And then I think once they bridge into the more intermediate and advanced phase, you start playing around with percentages that are estimated or calculated from a theoretical. So I don't think we ever really are like, let's 5 RM someone and see what we're going to use for the next 6 weeks. But I think we're like, comfortable technique, moderate load, could you do this for 8? And then second part, what's your RPE with that? Is it like piece of cake, or was I like, no, I was working? And we kind of play around with that. I personally don't calculate specific percentage of RMs. And
yeah, I'm getting feedback from them, like if they're doing, a rehab example is like shoulder stuff, shoulder sideline external rotation. I'm not stopping at 4 pounds, but if they can do 7, 8, 9, 10 pounds and they're getting a good burn at 6 reps,
yeah.
I think, that's a different thought process and phase in my head of a strengthening type phase, 6 reps, they're getting a good burn, let's stop there, versus maybe an in-season maintenance type program. They're doing 5 pounds, but they can get a set of 10 or 15 reps in. To me, that's just that's my way of judging, perceived exertion.
Pope's gonna knock some.
I don't know if you have anything
Yeah,
with your
Pope's just sitting back and waiting.
Okay, these guys are idiots.
These idiots that treat basic shoulder stuff.
I like the RPE. I think that's important for a lot of people that don't work hard traditionally in the gym. They don't really know what it means to work hard. They think that they have to use lighter load. A lot of times, especially when I'm doing manuals, so if we're doing like resisted external rotation or something like that, I tell people I want this to be like 7 or 8 out of 10 as far as toughness, And you have to play around a lot when you have pain. I think a lot of times when someone has pain, you can't really push as much. But when I'm trying to purely strengthen someone, I want it to be challenging. So I ask a lot of questions about that, especially from like a manual resistance perspective, because I'm not really sure how much they can tolerate, what they're feeling. So I just want to get a good feedback. But I tell people, was that about 7 or 8 out of 10. If they're like, oh, it's about 4, it's like, I need to pump it up a little bit. Or if they're like, yeah, technique's falling apart, 10 out of 10, that's probably too much, you know?
Right. So that's a good point from Dan. So if technique breaks down, that's usually not good for rehab, right? So we don't want that. So that's one big one. Yeah, I would say like post-op, sometimes it's a little easier post-op, right? Because it's almost like you're starting from zero. You're almost like, say like an ACL, you're doing a mini squat week 1, it's body weight, right? So you just do linear loading for me as you just kind of incrementally go up. And we're not, in rehab oftentimes, we're not working at a threshold to stimulate a ton of hypertrophy. We're not working at 80% of a 1 rep max. We're working at 10, 20% sometimes. So for me, it's linear loading, but I have a real simple way to do it. Is I start with something really basic and I ask, was that easy, moderate, or hard? And if they say easy or hard, I adjust. I want it in moderate in the middle. But it's almost like selecting where you go. Like sometimes I'll just look at somebody and think like, all right, how much would they back squat with the barbell on their back? And then I try to say like, all right, what's like 10% of that? Start there. Is that easy, moderate, hard? And then kind of go up. But I don't think any of us do anything fancy like, RPEs, like looking for, what is that, rating of perceived exertion, right? So I don't think we have an exact like scale we use, but.
We have the smiley face scale.
Yeah, oh, yeah, that's right.
The cry face.
Jojo, what's next? What's next?
All right, Josh from Virginia. Mike, big fan, love your podcast. What are your thoughts on performing exercises such as squats, deadlifts, and single leg movements barefoot?
This seems like something Dan would do. So Dan,
Barefoot and shirt off.
squats.
Yeah.
What was it? Squats, deadlifts, and what?
Yeah, single leg movements.
And single. All right. So lower body workouts barefoot. What do you think, Dan?
I think it really depends on the goals. I think that populations that can benefit from that are maybe foot and ankle patients. A lot of runners, a lot of times, are doing a lot of single leg stance stability. I think that's really good for athletes who are on the field as well. A lot of my athletes, they perform in shoes. They're doing a lot of Olympic weightlifting, so I think the shoe is very valuable for a lot of ways. It just depends on the person that's in front of you. In general, I think it can be a really good tool, but I also think you probably don't go crazy with it. I don't think you should do everything barefoot, but you probably have to get a good subjective from that patient and figure out what their goals are, and then it can make up just a part of your plan of care. I don't know if that helps out. But.
I think barefoot's. I hope barefoot's kind of getting less popular. I mean, for me, I know it's certainly less popular. I think as a gym owner, I think it's not the cleanest thing to do in your gym. But like, so let's say we're just not just talking barefoot, but maybe minimal or with socks on. Kind of use that. You can see with deadlift with like a posterior kind of like a posterior weight shift type thing is kind of what you want with the deadlift. That makes sense. But I always say, look, there's a reason why squat shoes exist, right? Squat shoes have a heel for a reason. It helps you with your mechanical advantage with your load, with your squat. It's easier to squat. That's why with the FMS, part of the thing is having your heels up at one point. So I'm not a big fan. I like to do my dynamic warm-ups barefoot sometimes, or minimal, or socks, because I want that proprioceptive feedback. I actually want to work my feet. But then once I'm training, I don't want to drop a weight on my foot. Not that my shoe's going to protect me, I guess, but whatever. But I don't know. Anyway, Jojo.
All right, Megan from Tennessee. I'm a PT interested in pursuing a dry needling certification. Any you recommend specifically?
All right, so PT looking for dry needling certification. Well, I mean, we don't endorse one, so to say, but like, I don't know. So we've all been through dry needling. Why don't we say what you've been through and would you recommend it? How about that?
Yeah, it's actually kind of neat. I think we all have different certifications here, so maybe this would be a good learning experience. I did something called SDN. It was my boss, Andy Free, and Doug is his partner, I guess, started the business. But they were in Connecticut for years, and they also trained under Chan Gun, I think is his name. Am I saying that right? But they took a lot of techniques from him as well as a Connecticut and developed their own system they like. I think in general, they don't try to attack the muscles as much, but they're still looking for a twitch response, which I think is a big difference between certain certifications. I can say from experience it's worked well for me, but I don't have a whole lot of experience trying other techniques either. I don't have a great answer.
Yeah, I took Dr. Ma's course with Sue Falsone, and I thought it was really good, like principle-based course, and they kind of sounds like similar. They took like some stuff from Gunn, they took some stuff from the dry needle theory, they took some stuff from a very Eastern philosophy kind of biochemical stuff, and then it kind of all got wrapped into like, this is our approach. You can twitch, you cannot. There's no research that says you have to or have to not at this point. So I felt it was a really good overview and gave you the basics you need. I had to do a lot of reading beforehand to make sure I understood it thoroughly, and the 3-day course was a little grueling, but helped learn a lot.
So that's cool because Dave went to Dr. Ma's course when Sue Falsone kind of took over. She was working with Dr. Ma for a bit. I went with Dr. Ma,
Cool.
which was kind of cool. Now Sue on her own has started her own, and it's not with Dr. Ma anymore. I believe, I don't want to speak out of turn, but yeah, it's called Structure and Function from Sue Falsone. So that's another one. So I did that, and I thought it was actually with Dr. Ma. I thought it was a fantastic introduction to it. But I will say, I then went to a Kineticore one, and Kineticore to me, I think really like unlocked how I use it. Like Dr. Ma's course, I feel like taught me the basics and taught me some great concepts to use that I still use this day, but Kineticore helped me apply it. And I don't know if that's because Kineticore is based on PT and movement, and the SFMA is kind of integrated a little bit, you know, and I'm sure Sue, by the way, and talking to her, I know Sue's kind of transitioned to that a little bit herself. So, you know, I'm a big fan of both. I'd definitely go to one of Sue's courses. Dr. Ma I think's fine, but I mean, if I had to choose, I think I'd go see Sue because one, it's Sue and she's a friend and she's great, but two is, you know, she's a physical therapist that does this, and I think I like that, right? But then I can't speak, you know, more highly of Kineticore as well.
Yeah, I did Kineticore. Mike and I did it actually in Atlanta a few years ago, and I thought it was well done. A good overview of anatomy, all the different layers that you need to pay attention to as you're putting a needle into somebody's muscle, and then applying it using SFMA, which all of us do. We seem to use SFMA a decent amount here, so just kind of movement assessment, applying that to certain muscle groups and needling, and you know, looking at pre and post changes, redoing the SFMA and seeing if made any changes, you know, and then just the research overview of why needling may work, trigger point theories and all that stuff. So I think it was a good overview. I recommend Kineticore for anybody looking.
Nice. Yeah, I mean, I think we all have some decent experience from a different bunch of groups, so I don't think you can go wrong with any of those. You know, I think that'd be good. So awesome. That's it, right? That's 3. Jojo nailed his first episode. Good job, Jojo. Jojo Coppola from Stony Brook. Anyway, thanks so much, guys. Appreciate it. Thanks for joining us on this latest episode. Please go to AskMikeReinold.com, click on that podcast link, and please leave us a review, a rating, subscribe to us on iTunes, whatever you could do to help us. But more importantly, go to that website so you can ask us questions, because we really want to hear from you guys. So thank you so much. We'll see you on the next episode.